This is Selma Schimmel for the group room at the San Antonio Breast Cancer Symposium. Joining me now is Dr. Christopher Twelves, Clinical Director and Professor of Clinical Cancer Pharmacology and Oncology, and Head of the Clinical Cancer Research Groups at the Leeds Institute of Molecular Medicine and St. James Institute of Oncology, Leeds, United Kingdom. Welcome, Professor Twelves.
Thank you.
Today what we want to talk about is what's happening on the metastatic breast cancer front, and in particular, the study of which you are the co-investigator and also contributed to the study design. I remember the original study was called Embrace. That study is passed. Where are we today?
It's maybe useful to start with that background and where we were a couple of years ago. The drug that we discussed then, and which we'll mainly discuss today, is a new cytotoxic. And that in itself is a little unusual because there's been so much emphasis on so-called targeted therapies in recent years. But this is a new cytotoxic called Eribulin. It has a novel mode of action. And the first major trial that we reported was the one that we discussed a couple of years ago. And that was a trial in women with metastatic breast cancer who were heavily pretreated and had effectively exhausted all the standard chemotherapy options. So in that study, they were randomized either to the new drug, Eribulin, or what we call treatment of physician's choice, which essentially means that in the absence of a regulatory-approved single drug, we allowed the oncologist and the patient to choose what the standard treatment would be. And to cut a long story short, the primary endpoint of that study was to show improved overall survival with Eribulin, and that we did. And subsequent to that, Eribulin was approved across the world in this setting of women with heavily pretreated disease. 2 years on, we're now reporting the results of a study that was conducted simultaneously, but has taken longer for us to get the results. And that doesn't have an acronym, but it's called the 301 study. And it's similar but different to the one we discussed previously. The similarities are, firstly, that we were again looking at women with metastatic breast cancer, but who had received an anthracycline and a taxane, but they were less heavily pretreated than in the Embrace study, where women could have received up to 5 lines of prior chemotherapy. In this study, again, the experimental arm was Eribulin, but here we were using a more conventional control arm. We were using Capecitabine, which represents for most of us the standard treatment that we go to when patients have received an anthracycline and a taxane. And again, we were looking for improvement in overall survival and progression-free survival.
What did the study reveal?
Well, it's an interesting study because it's a study where, on the one hand, the cup is half full, and on the other hand, it's half empty. It's important that we start with the predefined, statistically rigorous endpoint. And when we look at that, we didn't achieve the level of significance. We didn't achieve the magic p-value that we had predefined that would have established this as clearly a positive study and would have suggested that we could effectively replace Capecitabine with Eribulin. So we didn't achieve all of that. But what we did see was a trend, a consistent trend, for patients who received Eribulin to have improved overall survival compared to those who had Capecitabine. So there was a trend, but not a sufficiently strong one to cross that magical statistical barrier. And in effect, that means that in some ways this is defined as a negative trial, in that it didn't achieve its primary endpoint. But on the other hand, with these trends favouring Eribulin, I think for many of us we want now to look at those data in more detail and try and see what we can learn from the study.
What do you do next?
Well, I think what I feel strongly is that after many years of setting up a trial, a great deal of expense, but maybe most important of all, more than 1,000 women agreeing to be randomized within the study, consenting, helping us, I think it's important that just because we haven't crossed a certain threshold that we don't consider that the information should be discarded. So what we would very often do, and what we have done, is look at different subgroups of women to see if there are any hints as to those who may be more likely to benefit from Eribulin.
So do you begin them by a reanalysis of the data?
Yes, these are reanalyses, but it's important to remember that we have planned analyses. So these aren't arbitrary subgroups of women that we look at. These are subgroups of women who we defined in advance we would look at to see if there were differences in certain women compared to other women.
Breast cancer can metastasize to various places. So when you look at the profile of women with metastatic disease that participated in the study or would participate in a study, does their metastatic site maybe have an influencing factor?
It can do. In women with advanced disease who have received multiple lines of prior therapy, most of them have got several sites of disease. Most of them have got what we call visceral disease in the vital organs. So we do, yes, we look at the different sites of disease. We look at, in particular, the different molecular subtypes of breast cancer. And there are now increasingly sophisticated genomic ways of looking at breast cancer, but in this situation what we have available is dividing patients according to their ER status, their HER2 status, and looking to see what differences there are between those groups.
The process that you now have to engage in for the sort of the reevaluation period, how long does that take?
That's an ongoing process, and the data presented at San Antonio show that when we look at these different subgroups, if we look, for example, at the patients with HER2-positive breast cancer, and in those patients, it really looks as though there's nothing to choose between Capecitabine and Eribulin. But if we look at other subgroups, such as those with HER2-negative disease, with ER-negative disease, and in particular those with triple-negative disease, then there really is quite a strong trend favouring Eribulin, sufficient to suggest that those individual groups of patients may potentially benefit from Eribulin rather than Capecitabine.
Do you now continue following those patients?
We will continue to follow them, but unlike some studies which present their data when the data are immature, when most of the critical events may not have happened, in this population they've been followed for some years, so the data are unlikely to change in the coming years. What we are doing, though, is looking to see, as I say, how we can understand the data better, partly to suggest how we might refine our use of Eribulin currently, but also to look at what clinical trials we may do in the future to look as to where Eribulin heads.
Is there anything, as you have reviewed the information you have so far, that strikes you about signs? Have you learned something? Is there something that for you, when you look at, has a little light that goes off for you?
I suppose there are two sides to this. The first is that although the study was technically, as we say, as the term is, negative, that from the scientific perspective we're seeing quite encouraging signs suggesting that these triple-negative patients in particular, but also those who are ER-negative, that those patients may be ones who would benefit. The other side of this is that, although it may not sound quite as scientific, an important element of what we get out of a study like this is more information to discuss with our patients. Because there are patients that we see regularly, patients for whom either Capecitabine or Eribulin would be an approved option. And now that we have a head-to-head comparison of the two, we'll be able to sit down with our patients and discuss what the possible benefits of Eribulin or of Capecitabine may be, what the different side effects may be. So in addition to the very raw statistical information, we've got additional, if you like, personal information that we can say that the indications are that a particular group of women may benefit. We can say to them what the differences in side effects may be. So I think it's important that we learn from these data to give women more opportunities and more choice. no, these are exciting times for us as doctors, having more options, being able to talk to our patients with more hope about what we can offer them for the future. And I'm confident, talking to the patients who take part in studies such as these, that obviously they hope that they themselves will benefit, but they also hope that future generations, the many other women with breast cancer, can also benefit from the trials.
Thank you, Dr. Christopher Twelves, Clinical Director and Professor of Clinical Cancer Pharmacology and Oncology, and Head of Clinical Cancer Research Groups at the Leeds Institute of Molecular Medicine and St. James Institute of Oncology, Leeds, United Kingdom.
Thank you.
Thank you for making time.